All right, so we're going to start with chapter 60, which is diabetes. There are 3 different categories of drugs that we will be discussing. The first is oral hypoglycemics. These aren't in the order in which I'm presenting them, which annoys me. But we're going to discuss oral hypoglycemics, injectable hypoglycemics, and then hyperglycemics. Okay? So, like I said, in order for you to understand how a medication is going to work, what you need to know about it, what you're worried about it, and how you can safely administer, I first need to understand what's going on in the first place, right? And then I can understand how this medication is going to fix it. Okay? So, what is diabetes?
Type 2, I think you just have like insulin resistance or something. Enough into your body for the insulin.
My pancreas isn't doing what it's supposed to do, right? Either, or maybe my pancreas is, and my body is now too desensitized, right? So those are pretty much the things that can be going on. And the problems involved in diabetes are what? I got 2. Hyper and hypo, right? I can have high blood sugar or I can have low blood sugar. And with diabetes, it's going to be one or the other, right? I say this is probably not a fair statement or true to say, but it's minimally normal, right? Because that's my goal. I have to do something, I have to treat them in order to make it normal, right? Otherwise, it is not going to be. So, I know that this is going to involve their blood sugar. That's the gist. So what is normal blood sugar? What are we saying? What are your what did you just test on? Do y'all know? Okay. I say 70 to 100. I will ask Miss Seymour what she's going to tell y'all, and we'll be on the same page. Is that right? I mean, is that fair? Okay. And I will let y'all know what the expectation is. So, we said that it could be high or low. So what's my goal with treating diabetes, administering medications? I want a stable blood sugar. That's my goal. Okay. So what would I be worried about when I'm treating somebody for diabetes? Because I know that this is going to drop their blood sugar, I would want to know what that is before I go give it, right? Because I already know. I know that's how it works. I know that's what's going to happen. It's not going to not happen just because I don't want it to. I need to know what their blood sugar is before I go give insulin. Same thing, if I go give a hyperglycemic, what do I know that's going to do? It's going to raise their blood sugar, right? If I give them a hyperglycemic, it's going to bring their blood sugar up. And I would not want to do that if their blood sugar is already high, because they're going to have symptoms of either one of those things, whether it's hypo or hyper. So how will I know that it's working? How will I know that I did the right thing, or what am I monitoring? So that is one of the biggest things. Yes, 1,000,000%. I want an objective number. I want to measure their blood sugar. Most of the time, I do that by what? A glucometer. Look at you. So what is so I probably got ahead of myself in that. Um I might circle back to that question. But what Wendy said we're going to do is I'm looking at my patient. I am looking at them and I am determining whether they have signs and symptoms of one or the other, right? Because truthfully, if I'm doing any intervention, what is supposed to be my next step? I'm supposed to evaluate if that worked, right? So I'm supposed to look and see if I just gave you insulin, did this do what it was supposed to do, right? However, how did y'all say I needed to do that? Check their blood sugar, right? So if I have orders that tell me that I'm supposed to check somebody's blood sugar before meals and at bedtime, that is minimally 4 times a day, right? And then every time I'm doing that, my patient's complaining because it hurts, because that doesn't feel good to be poked with a needle, right? So then if what I think that I'm supposed to do is then go check it, if I had to give them insulin, or even if I didn't, I'm going to reassess, right, to make sure that that was the right action. Now I've just turned that into 8 times, and I'm sending them home. What is the likelihood that they are complying with that? They're not going to, right? So most of the time, what you're going to do is I am going to evaluate them. I'm going to teach them what are the signs and symptoms of hypo and hyperglycemia, and I'm going to assess that. I'm going to tell them to report it to me, or I'm going to look for those things myself. And then if I suspect one or the other, right, if they have signs and symptoms, then I can check their blood sugar. Then I can have that to confirm. But after they have established treatment. Now, early on, are you rechecking it more frequently? Yes, I need to know how their body's going to respond. But this is probably one of the only things that I'm going to tell you, and this might not even be textbook what I'm supposed to be telling you, but this is real life. People are going to hate you if you walk in and out of their room 800 times to stick their finger. When, if I just gave you insulin, what do I know is going to happen? It's going to drop. If I just gave you sugar, what do I know is going to happen? I don't need a value to tell me that. I have an order that says I have to do this before me. I'm going to be back in a couple of hours to do this again. Now, if I suspect that that's wrong, that something's happened in the meantime, check it 800 times if you need to. But does that make sense to everybody? You are evaluating it, but it's going to be based on those symptoms mostly. Before I administer it, 100% I have to have a number. I have to have something to go off of. And once I get my number, what is my sliding scale? Oh, yes, that's my symptoms. 100%. You ready? So that's hypo. Cold, clammy, I need some kid. That's right. That's my symptoms. Tell me my sliding scale. You just said it, didn't you?
Oh, is it 300 minus blood sugar over 20, or is it blood sugar minus 300?
Blood sugar, blood sugar minus 100. That's okay. That's why we're doing this, because y'all gonna be expected to know it. Blood sugar minus 100 divided by 20. That's the sliding scale for the number of units that I'm going to administer based on their blood sugar. So if the blood sugar was 300, then it would be 300 minus 100 divided by 20. That's 10. Go ahead, Roland. That's the formula. Does that make sense? That's how I would implement that. Now I'm going to show y'all either today or at some point a different sliding scale of what that might look like, because I think that they gave up on counting on people to remember that. Y'all have to. But in real life, they might have given up on people remembering how to do that, and they just have a standard scale where you look at it and says their blood sugar is 100, you give 10 units. Okay? They kind of took the math component out there. Unfortunately for y'all, that's not the case. So I think that was all that I wanted to say about those things. All right, so we're good on diabetes. We understand what we're doing here. Great. Okay. So, here is a little picture of just what is going on in that process in the body when you either have a high blood sugar. I'm trying to stay close to this because y'all told me and my head flipping tonight informed me. Is why y'all can't ever hear me on my recordings because I don't pay attention and what I'm doing. Okay, so the high blood sugar is going to, I'm going to eat something, right? And then what happens? My blood sugar goes up. And then what happens? My pancreas says, here's your some insulin. Now, what does that insulin do? It's going to go act on them cells and tell my body to use that sugar, right? Put that into action, get you some energy, get your brain some energy, right? Um, It also is going to tell my liver to store some of that for later, right? And in turn, what's going to happen? Now that I've got insulin, now that my sugars are in my cells, now that my liver's storing, what's going to happen? My blood sugar is going to go down. This is what happens all day long in our bodies. This is just the normal process. Our insulin does this if it works correct. If it doesn't, that's where we have malfunction, okay? So if my blood sugar is low, then what happens? It does. What'd you say? It does. So glucagon then triggers my liver to release that glycogen to get me some sugar, right? So that's it, it is trying to raise my blood sugar. Okay. Now, if I don't have uh, if I don't eat to supplement that and it is severe, I'm going to have what? Yes, I am. I'm going to have hypoglycemia. And that is going to look like, there we go. So that is what I'm looking for. If I recognize that, that is indicating that there's low blood sugar. Okay. So, um, a patient with hyperglycemia will often present with what? There's lots of P's here. Hey, good job. So they're going to be peeing and they're going to be thirsty and they're going to be hungry. Okay? That is hyperglycemia. So the different ones that we are going to talk about, like I said, as y'all are doing your drug cards and we discuss different things, classification is going to be probably an easier way to remember things rather than in learning individual drugs because certain classes might have beta blockers, for instance, has probably 10, maybe more. I can't even tell you right this second different medications under that classification. Mostly they're going to do the same things. There might be odd things about different ones, but then that's only you remembering one thing about one drug versus 100 about 20 different drugs. Does that make sense? So the way that I'm going to present things is by class for the most part. So the different things that we'll discuss in this section are going to be injectable hyperglycemics, which is dextrose and glucagon, injectable hypoglycemics, and then that's all the classes that fall under that, and then the oral hypoglycemics, and then those are the classes that fall under that. I'll tell y'all that later. Okay. So insulin, we've already talked about this some. We said that it is going to lower my blood sugar, right? That's how it functions. That's what it's supposed to normally do in my body. And if my body isn't functioning correctly, I might have to supplement with that. Okay. So most often with insulin, this 100% has to be given to patients who have type 1 diabetes. Okay, that is what they are going to be treated with. Um, Sometimes it's given to patients with type 2. Most of the time, that's just because it can't be controlled otherwise, or they're in some period of stress or something like that where their body's having an increased need. And then in gestational diabetes, most of the time, this is what is used. So there are 4 different types of insulin. There are rapid, short, intermediate, and long-acting. Um, for each of those drugs, you are going to be responsible for knowing, or those classes, I guess, the onset, the peak, and the duration. And it is important for you to know those things because that is 1,000,000% what is helping you make decisions on is it safe to administer them. Okay. And what side effects am I looking for and when, basically. Okay. Um, so this insulin is going to function the same way that it does in my body, my normal insulin does. The different time frames and when those act are going to help me determine when they should be administered, like what time of the day, or if they have to be administered with meals or things like that, or when they could still be causing an effect, even if I didn't just give it, right? And what side effects to look at. So, in addition to the things that we said insulin does, it also helps our cells to use potassium and move sodium out. Okay, so if I take in too much insulin, what are 2 things that could happen? Hypokalemia, right? And what else? What are the 2 things, bad things, that could happen from me giving insulin? What would I be looking for? What's it going to drop? Sugar. So hypoglycemia. Y'all think I'm tricking y'all. Hypoglycemia and hypokalemia, right? So I might have low potassium and I might have low blood sugar. Those are things that I'm monitoring. Okay. Um, mhm. So for um a lot of these slides, I'll just give y'all a little heads up, I guess. Things are written and repeated on some of the slides and maybe written in a different way. And I left that in there because people learn different. So I'm going to try not to repeat things, but I will go over what's different. Okay. So if I'm skipping over something, that's why. So, when I might administer insulin, obviously is going to be when their blood sugar is high. When else might I give it? Based off what we said on the other slide.
Are there?
If their potassium's high. I have actually had a situation where I came into the hospital and I was getting a report on my patients, and the night shift nurse was giving me a report, and she told me that the patient's potassium level, there we go, was 6. Which normal is 3.5 to 5.3, and you don't have much room on either side of those values. And his was a 6. And it had been that way all night, but she couldn't get him to drink the K-Exolate, which was going to help him get rid of the sugar. I mean, the potassium. And I went into his room, and he was almost comatose. Um, and so I called the doctor, and we transferred him to the ICU. And one of the things that he told me to give him was insulin. That I could give that without having to put anything in his mouth, right? Which they give rectal KX-Late too. I'm not sure why she just decided she wasn't going to give that, but that was a honestly I had never seen that before that time. But that is an option. Um, for also if my first line of treatment, if this is type 2 diabetes, I'm going to encourage a patient to change their diet, right? Limit their carbs, get some exercise, lose some weight. A lot of times that helps, but plenty of people are not diabetic anymore once they lose weight, change their diet. So if it doesn't work and I'm giving them oral medications and that's not doing the trick, then we might have to give insulin. If they have renal or liver disease, that could be the case. If they are having surgery or they're sick or they're like everybody that y'all are going to encounter as nurses are going to be stressed, which is going to increase their need for insulin. So a lot of times patients won't be on insulin at home, and we're giving it to them in the hospital just to supplement while they're there. So they won't go home on it either. It's just while they're there, we might need to supplement with that. If they're in DKA, or as y'all said, if they have hyperkalemia. So, the first one that we will talk about is rapid acting. When do y'all think that's going to act? Rapid. It does act rapidly. Look at y'all. Um, so if I know what insulin does, it does what? It it lowers my blood sugar, and this is going to happen rapidly. What do I need to make sure that they are doing? Eating. So the rule with this is food on fork. They have their food on their fork and they are eating, right? Like this needs to happen immediately. They need to be eating with rapid insulin. Okay. Right before a meal. So the way that this is ordered, and this doesn't last very long, we'll see that on a table in a second, but the way that this is ordered is based off of how it works. It works immediately and it doesn't last that long, which is why my orders say that I need to check their blood sugar before meals and at bedtime, and that I can then give them rapid acting insulin based off of what their blood sugar is, because it's going to fix it. They're going to eat. It's meant to sustain their blood sugar after they eat and then or with a meal, and that should sustain them until the next time it's time for them to eat. Okay, so that is when that is going to be ordered, the rapid acting insulin. Most of the time, what you're going to see ordered, this is probably what most of you will be giving. Y'all, probably every single one of you will give every kind of insulin before this program's over. But most often, what is ordered with sliding scales and as just kind of the standard order is rapid acting insulin. So that is Humalog or Novolog are the meds that you would be given. Humalog or Lispro, those are the most common that I've seen. And for short acting, both of these are given sub-Q. Short acting or regular insulin can also be given IV. So if somebody has an insulin drip, generally they're going to be on regular insulin. People who get an insulin drip, when you would have IV, like a continuous drip of insulin, most of the time those people are in DKA. That's when they would have that ordered. The Look at you. So our tubing has to be changed every 48 hours. So for the this also can be given before their meals. And this also can be given before they go to bed at night. And again, it's just to stabilize them. Most of the time, if you're giving insulin at night, you want to ensure that they have a snack, like, because that's the point, right? That they're supposed to be eating with that. There are different concentrations of regular insulin. And what you administer needs to be, you need to use the correct tool or syringe based off of what you're administering, or that's going to be a very big difference in what you're giving. Okay. I have a picture of that in a couple of slides I'll show y'all. I think I have this, I want to ask this question, but I think I'll ask it later. So here is a picture of what that could look like. So, what do I have to do? What is a rule when I administer insulin? What do I have to do? A licensed nurse has to verify this every single time. And I'm going to tell you, as somebody who has given countless amount of insulin, it is aggravating and seems like a stupid rule that I drew up two little units, two little of insulin, which like you could barely see in the syringe, and I have to go hunt somebody down and say, "Can you sign off on my two little units of insulin?" And I cannot tell you how many times that I cursed that experience until twice. I have had somebody walk up to me and they have been supposed to give 4 units, excuse me, of long-acting insulin, and they drew up 40 of regular insulin. And that right there told me I want somebody to check behind me. I don't want to be willy-nilly just giving things, and I absolutely will not sign off on anybody until you show me what it is that you're giving. So it's still aggravating. I don't enjoy that process, but I enjoy not killing people and signing my name to that. And you are just as guilty if you sign. So I encourage you to say, show me that. Because plenty of times people will just sign their name and walk out the door. And that is still on you if you decide to do that. Okay? And I don't want to kill people. So you can see here that this is demonstrating that basically this is 5 times more concentrated than this one. So this is the same amount of insulin. The blue is the same amount of insulin in this syringe as it is this one. So if I got confused and I was accidentally using this syringe and I remembered that it needed to be up here, I just majorly killed someone. Does that make sense? So be mindful and have somebody check behind you. It is very, very important. NPH or intermediate acting, this onset is delayed. So I have a little bit longer before this kicks in. So this isn't with meals. Now, I don't necessarily like how this is worded where it's not given with meals. It's not that it can't be given with a meal. It could. It's not impacting that. It's not going to drop their blood sugar to control their post-meal insulin. Does that make sense? This is more of to keep it stable. Most of the time, this is given 2 to 3 times a day to just kind of keep a, if y'all learn the word basal, have y'all learned this, like a basal rate, that's pretty much what this is. You're just keeping their blood sugar at like a steady rate. And this is helping me do that by giving it more frequently. And it can be given at bedtime again because it's not going to kick in immediately. The NPH, this is going to be the only insulin and one of very few that are cloudy, and they're supposed to be. Okay, why is it cloudy? It is. So, it's 2 different kinds of insulin mixed into one. So it is, in fact, it's a longer acting insulin and a protein that helps it not to work as quickly. That's what the NPH itself is. But because it already has regular insulin in there, these aren't the best examples, but I'm going to show you. Because it already has regular insulin, and it's a combination of things in here, it's cloudy, and it's supposed to be. So when I administer this, I expect that it's going to be cloudy. If I'm giving any other kind of medication, any other insulin, it should not be cloudy. Okay. So when I give these, I make sure that I roll it to distribute that medication. Okay. I'm not shaking it up and causing bubbles or whatever. I'm gently just trying to roll that. Have y'all played with these? Have you seen? Okay. So you saw it distribute, right? Like you see that precipitate kind of move through there. So this can be, because it is already has regular insulin in it, can be mixed with regular insulin. This is also the only insulin that can be mixed. Okay. So when you see medications like 70/30, what does that mean? It's the intermediate, it's the NPH, and the regular, right? It's the percentage of those mixed together. There's 60/40, there's different concentrations of them. This would be what you would prefer if you had to mix them because they're already mixed. There's no room for error. If I already know that I have to mix it, this would be what I would prefer to give. In fact, a lot of places don't even want you mixing insulins anymore because people don't know what they're doing and they mix the wrong ones. But just know that NPH is what you can mix with um, regular insulin. So, long-acting insulin, this is usually given once a day. Sometimes it's given twice a day. I don't know that I've ever even seen that, but most of the time this is given once a day. And again, this is for that basal coverage. So if a person has type 1 diabetes, they are going to be on a long-acting insulin because their body is not going to produce it, right? So this is basically, I think about this as this is their bodies. This is just their body's insulin. This is what they have to have. I'm supplementing it. Now, the in addition to this, they will check their blood sugar before they eat, maybe even more frequently, but let's just say before they eat at bedtime, and they might supplement that with rapid acting or short acting insulin. But this is just that basal. I know that they don't have insulin, I have to give it to them. Okay. These last a lot longer. These should be not mixed, and I will tell you the trick with this because I've had in simulation, I have an order for students to give this and regular insulin, and it's always a question of whether they should mix it or not. So, what what is the rule? I have it on another slide, but we'll go ahead and just ask it. What is the rule for when I mix insulins? So clear then cloudy, right? That is my rule. So if I look at this, if I look at this Lantus, is it cloudy? So what am I supposed to draw up first? It's a trick. I'm not mixing it because it's not cloudy. That's right. Look at you. So maybe they have their insulin pen, right? But yes, I'm not mixing this. And my clue is because I know that I have to do clear before cloudy, and this ain't cloudy. And so now I'm confused because I got two different clear ones. That don't make sense. Now I'll say something that does happen, and this isn't necessarily in this, but this is just for your knowledge. Sometimes patients will have an order that says you give 7 units of Humalog before meals and at bedtime. And then they have a separate order that says you give Humalog per sliding scale before meals and at bedtime. Okay. So I go check their blood sugar and it is 200. How much insulin I gotta give? I'll believe you. So we'll say I have to give 5 units. So 5 units. And then I had an order already for what? For 7 units of Humalog. And now I have an order to give 5 units of Humalog. So what can I do? I can draw up 12 units of Humalog. Okay? I don't need two separate. Does that make sense? That's not two separate drugs, though. But sometimes you will see those orders, and it can throw people off. So it doesn't matter with the long-acting insulin when you give it. It's not going to have any impact on their meals. It is just steady, but I do have to give it at the same time every day. That is an important part. Um, this for the premix, I already talked about that, the 70/30. That's just the mixture of what you normally would be combining with the cloudy and clear. I will tell you that I have not done that in a very long time. I think that they just gave up on people mixing insulins. Um, but you never know. You never know where you might end up. Um, for this next the chart on page 667. There is this chart of your onset peak duration. Like I said, this is very important for you to know, for you to be able to anticipate when you're looking for those side effects and if it's safe for you to administer this. Okay. So in looking at this, just when would I hold rapid acting insulin? When would I not give it? If their blood sugar low, if they're not eating, because I said they had to take it with food. What else? What'd you say? I probably am going to give them potassium. But yes, that is something I'm looking at. What else? If I had already given it to them, if they're going to sleep and they're not eating, right? If I'm scared, most of the time they do have orders for at bedtime, but like I said, they need to eat a snack with it. What about when they're throwing up? That would not be a good time for me to give somebody insulin, right? Because they're throwing that up. What about long-acting insulin? When would I hold that? Hold it. What'd you say? Okay. If I've already given it, they've already had it, which would be really important. Like if my patient comes into the hospital and the doctor continues their home medicines, and let's say they get to my floor at 2 p.m. and I'm just going through getting their medications together and I just decide to give them insulin, it would be a really good thing to ask first, right? Like had they already administered it. Um, would I hold it if they were NPO? What would help me make that decision? Physician and their blood sugar. That's correct. Most of the time, the rule is going to be that you don't hold it. Now, what would make me decide that I was going to hold it? What would make me, you said the blood sugar. Very good. So my story, back to the guy who we went to go give him medicine, and 3 days in a row, his sugar bottomed out overnight. Why am I giving you this? Like, obviously, this is too much, right? Because I'm looking back over a 24-hour time frame of what happened. So to make that decision, if my patient, let's say my patient comes in, this is a scenario. Have my patient come in. They are lethargic, they're cold, they're clammy, they're confused, blah 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 blah. That's how they're talking. Okay, that's my patient. And I check their blood sugar and it's 48. And I give them some insulin. No, I do not. Would not do that. Give them some sugar. Okay? I give them some sugar. I get their blood sugar back normal. I go look at my orders and it tells me that they have long acting insulin due. They got Lantus. It's scheduled for right now. Would I give that to them? What would I want to know? So if my patient took their Lantus yesterday and they ate like normal, they exercised like normal, they're living their life and nothing has changed, and today they crapped out on the floor, I'm scared. I don't know what's going on. If I if I talk to them and they tell me, "Oh, I forgot to eat. I just exercised. I did." It's not the insulin causing that. It's that they weren't eating. And does that make sense? So those questions, those assessments are going to help me make those decisions of what are the circumstances surrounding this? What did that last 24 hours look like? But most of the time, I'm giving that basal insulin. You generally are not holding that. If you do, you need an order to do so. So you need to call and say, this is what's going on. Should I give this or not? Okay. Does that make sense to everybody? Okay. So, before I give insulin, I'm going to assess blood sugar. Have y'all learned how to do that? Cheyenne did. So, did y'all learn that in class? Oh, okay. All right. So y'all are probably going to be expected to check blood sugars at the hospital. Okay. So what you do is you get a little alcohol and you get a lancet. Okay. And I'm going to be real um safety and quality right now. But I do need gloves and I do need alcohol and I need a lancet and I need a glucometer and I need a little strip that is somewhere to put in that. Now, the ones that y'all are using at the hospital are going to look different than this. Your teachers are nicer than me because I would have made y'all already check blood sugars on one another. But but in order to do this, what I have to do, and I would encourage y'all to do that at the hospital. If y'all don't get in trouble, that's why I usually like to do it here because it hurts. And I want you to know that because I've had students come to me and tell me that they tried to get somebody's blood sugar 5 different times. And I'm like, well, that's not very kind, for you to do that. So the method is, and I'll do it quickly, whatever. We're gonna clean, okay? Clean our finger. I do have gloves. I do wash hands. I do all those things. Yeah. Oh, Gavin's gonna do it for me? Okay, go ahead. Uh, you can start the contact. Okay, so this is the link set. So to open it, you twist this little paper part of it, you pull that off, and there is a needle under it. So don't stab yourself. Okay? So I'll take that off. Hold on. Well, yeah. Do you have a glove? I love that. Safety first. Okay, so you can um whatever hand you're gonna use. Are you looking? Do
Okay.
okay. I'm just going to take a so we twist this little thing off, and I'm just gonna do it for show and then I'll let you do it because everybody gets confused. I'm doing it. So I twist this little part off. Okay. it twists and pulls up. Okay, under there, y'all can see, and it's not a needle on the edge, but when you push this button, that's a needle. Okay, so what I tell people is to kind of like push up against the side of your finger so that you have some meat there to use. Okay, so you push up against the side, and y'all can practice along with me if y'all want to, so y'all can feel. We're not going to stab each other, but y'all can see the process. So you push up against the side of it, and you want to use the side of their finger, not the pads. Okay, so I push up against it, clean it with alcohol, and then I push this flush. Make sure you're pushing hard, and then I push this. Okay, that's the needle. Once they push that, there's going to be blood because it's the needle. Okay. Now the next move is that you take a little cotton swab, you wipe that first little drop of blood. We're not doing that because we don't have it. And then you're going to take the next drop. Now I'm going to tell y'all that you have to actually press. It's not, people try to be cute with a little, no, you have to squeeze their finger to get the blood. Okay, and you're going to get a drop. And for whatever reason, people do not understand this, but there's a drop of blood, and you have to scoop up under it so that it slips in the end of this little strip. Okay, so on here, this is like flat, and it's going to suck in there, but you have to get it under that little bubble, because or else what I've seen students do 872 times, plop it right on top of it, and they're like, I don't know why this is working. It's because you didn't get the blood in there. So that's the method, okay? So we'll go ahead. You can push this in here. Have it ready. He's here. He's here.
I don't know. That was
Maybe you should turn around. Maybe you want to stand up here? Or is everybody good? Y'all get it? Okay. We'll hold my hand up too. Go with the X in our heart. Okay, so once he stuck that in, like I said, y'all is gonna look different, but for the home ones, once you put the strip in, it just comes off. And it's just waiting on you to put blood in. Okay? At the hospital, usually you verify who they are, scan their armband, scan yourself, then you do the same procedure. Okay? I'm thinking you would have done it. You better do it right.
on the side, like right there.
Yep. You're not gonna.
Better.
I don't think you got that part. It's fine. So we're going to actually push it. Like move your finger and do like this. I want you to do it. You have to be careful and be right up. I don't. Okay, got it? And then it's up to like. Wait, you did it. Look at you. And then this, very, don't do that. Very important. This is the shark. Okay, so this goes in the shark. Can't tell you how many students I've seen throwing this in the trash can. It's not where it goes. Okay, now I'm gonna very unsanitarily continue teaching. And then you have your value, and you tell your patient what that is. Great job, Gavin.
Oh, wait, no, never mind. That's for you.
So if I have, we can just do it. It says it's 107. Okay, 107, and I would divide that by, no, subtract 100 and divide by 20. How much insulin am I giving? Zero. Great. Okay.
7 units, let's go.
Okay, was that helpful? It's fun, huh? Okay, so that is a process. I have to do that before I can give them insulin because I don't know what their blood sugar is otherwise. The only other way I would know that is if somebody else did it, for one, and they had to have just done it, or if they happen to have just ran labs and it comes back and tells me what the glucose is. Okay, but in general, I'm checking, and you might see that as CBG, which is their capillary blood glucose, or you might see that as POC, which is point of care glucose. But either way, that's what it's referring to. That I, with my little machine at their bedside, checked their blood sugar. Okay. So I'm going to check their blood sugar. And then based off of that, just what y'all did, I'm going to make my decision on whether I need to give that or not. Okay. Um, I make sure that you look at your insulin, make sure that you check the dates on them, and then again, based on the patient's presentation, is how I would do that. So y'all told me y'all have already done the clear and cloudy thing. Y'all have seen that? Okay. I'm not gonna make y'all do that then, but I will. I do just want to remind you that you have to know that. You have to know how to do that. And then also that you are familiar with the different types of syringes. So I'll pass these around just so y'all can see them. I don't know which ones y'all have, but this goes back to being familiar with your equipment, whatever. This right here is a 50 unit half milliliter syringe, and this is a 100 unit 1 milliliter syringe. Can you tell the difference sitting from there? Not a whole lot, right? It would take me paying attention. And so what this would look like, I can just show you. Go ahead. Why don't you draw me up 30? So you should only use insulin syringes for insulin. That's a good question. I can only give insulin using an insulin syringe. Okay. So just to look at what they've drawn up, I have 30 units. Do y'all see the difference? That if I accidentally gave that much more insulin, that's almost, that is double. It's at 60. So just be mindful of what you're administering, okay? So those are just important for you to be aware of the equipment. And I'm glad that you asked that. So yes, you only can use insulin syringes to give insulin. And you should use the smallest necessary. So they even have 30 unit syringes instead of 50. So if I have to give 3 units, I would rather use a 30 unit syringe. Okay. If I have to give 35 units, I'd rather use a 50. If I have to give anything over 50, then I have to use 100. Does that make sense? But you would like to use the smallest one. So sub-Q is generally how these are given. If somebody has type 1 type diabetes, a lot of times they'll have insulin pump, and they also can have the continuous monitor, which helps to break down. First of all, it gives them better control of their insulin because it's monitoring it more frequently, and then they're able to administer it more frequently. But the pump, it is the biggest concern with that would be to make sure that you turn it off. Like if they were to have surgery or something like that, where they're not eating, they're not able to use that, especially if it automatically gives them medication. If you give it with using an IV, make sure that you waste the first 50 milliliters to ensure that they're getting the proper concentration. You also can give it by inhalation. I've never done that, but same principles. They should be stored in the refrigerator. If they've opened them up, then they can be kept at room temperature for a month. After that, they have to be discarded. In the hospital, it depends on where you work, whether they have it in the fridge or whether they have it in the like just in a cabinet or whatever. But I promise you that insulin is not lasting a month in a hospital. You're using it all day long. It really just depends on the pen. It depends on the insulin. So kind of same concept. If it's a month, then no. Most of the time people keep them in the refrigerator. Um, no direct sunlight, and then make sure that you, if you do have the pen, that you mix it around. So complications, we know that that would be hypoglycemia. So they might have tachycardia, they might have palpitations, they might be cool, they might be clammy, they might be confused. It can be up to them having a coma. Or death or seizures. So we want to control that. That they can cause irreversible brain damage. So we definitely want to make sure that we're closely monitoring that, especially picking up on if they are having symptoms. So if they are hypoglycemic, if they're having symptoms of that, I need to get them sugar, right? What would be the preferred method? Yes, their food. That's what if your sugar is low, you're gonna eat food, right? So I'm gonna give them some candy, give them some juice, give them something to get their blood sugar up. But what if they are seizing or confused? I can give them dextrose or glucagon. Dextrose would be preferred, especially in an emergency, but if you don't have that, glucagon will do the trick. But usually IV dextrose is what you're administering. I think I brought that. I must have didn't. But dextrose is usually comes in, I'll try to bring that next slide so I can show you. Just because it is different. It's a 50 milliliter syringe, so it's humongous. And you have to connect a little adapter and then you attach that to an IV. So just know, I'll try to remember to bring y'all that. Here are the steps. Y'all told me y'all know how to do it, so I'm not going to walk you through that, but that's how you would mix insulins, and always have another nurse verify. I would be worried about hypoglycemia, we said, hypokalemia, lipodystrophy or lipohypertrophy is just because I'm giving that. Where do I give them? Sub-Q. So I'm giving it in that fatty tissue. And so if I give it in a site too frequently, too close together, then it can cause issues with the tissue. Okay. Or they can have allergies. Usually it's given sub-Q. Like I said, we can also give it IV or inhaled. And then it can, if they're taking, these are both oral hypoglycemics. Obviously, if they're taking those, they might be at a greater risk for their blood sugar dropping. But also, if they take beta blockers, so beta blockers slow their heart rate down. And because a symptom of hypoglycemia is tachycardia, they might not recognize that their blood sugar is dropping because they're not experiencing that. So that can put them at a greater risk for hypoglycemia. Salicylates, and then alcohol. So now we're going to get into oral anti-diabetics. We talked about that. So the first one we'll go over is sulfonylurea, which is a fun word. This was actually the first oral hypoglycemic or anti-diabetic that was available. It works by binding to that potassium channel and promoting insulin release. So this causes increased insulin production. It can be used only for type 2, so a type 1 diabetic is never going to get this. And it can be used in conjunction with giving them insulin or metformin, which we'll talk about next. Or I guess I should have said. The side effects with this are weight gain and hypoglycemia. So the two drugs that are the first generation are these more Second generation are used more commonly. I've given all of these plenty of times. You do have to look out for cardiotoxicity. So if a patient has like cardiac diagnoses, if they have heart disease or heart failure, things like that, then I would want to possibly not administer that or at least be cautious of that. It does have drug interactions. So if you give this with alcohol, it can have an anabuse type reaction, which if y'all don't know what that is, it is a drug that helps people not be alcoholics, and it makes it when they drink, they violently throw up and are very, very sick. So that would obviously be contraindicated for me to administer this to somebody who's an alcoholic because they're going to drink. And then on top of all the other things they have going on, now their blood sugar's low because they're puking, right? I guess it does have the desired effect, but you know. Other things that can make that hypoglycemic effect higher would be sulfa antibiotics. So Bactrim is a common one of those. NSAIDs, if they're taking anticoagulants, so Coumadin is a common interference with this. And then thiazides are going to counteract those hypoglycemics. And then same thing with salicylates, MAOIs. Those are, you will see that a lot, MAOIs, of that counteracting different things. So I think that's all I want to say about those. All right, so next we have biguanide. So the only one of these is metformin. It's also known as glucophage. This is very commonly given, and usually people don't have as bad reactions to this. It's not as big of a risk for hypoglycemia because of the way that it works. So it basically increases the insulin sensitivity. That's the function of it. So it decreases the absorption from the intestines, decreases glucose synthesis by the liver, and then increases the sensitivity of insulin receptors. So most people who have diabetes, this is their drug of choice. I would say especially for type 2 diabetes and even gestational. Side note, this has nothing to do with your test, but I recently read about metformin, and supposedly it is a derivative of some natural, is it lavender? I can't even remember what it is, but it's some natural something that is like the fountain of youth. So do with that information what you would like to do, if you'd like to read up about metformin. But it is supposedly also helpful in protecting you against like cardiovascular type issues, which having diabetes puts you at risk for. The most common side effect, 100% GI upset. I would say diarrhea is one of the biggest side effects of this. Lactic acidosis is rare, but potentially fatal side effect. So if patients were at risk for lactic acidosis, like they're alcoholics, they're septic, they're doing some sort of intense unusual exercise, then they might be at risk for that. It does have a metallic taste, which I would want to tell my patient because a lot of times that can be off-putting or might cause people not to take it, and also can cause B12 and folic acid deficiency. So those would need to be monitored and potentially them take supplements in order to counteract that. It is used also for PCOS because of its ability to help with insulin sensitivity. For the interactions, we'll talk about that on the other slide. So on here, we'll talk about meglitinides and, good God, thiazolidinedions. Yeah. Thiazo, I had it the other day. Y'all do what you want to with that one. The meglitinides, that is going to act similarly to sulfonylurea. So the function of that is going to be very similar. So it increases our insulin production. This is used just before meals to decrease that post-meal blood glucose rise. Okay. Um, it is shorter acting, and it causes a greater increase in the drop, basically, a greater decrease of the blood sugar. So this is similar to insulin of having to administer it and make sure that they're eating. I would want to make sure that they're eating with these drugs. The major side effects of this would be hypoglycemia, nausea, vomiting. It is important to note that if they were taking glibocide or glyburide or something like that, the sulfonylurea, that if it didn't work, this isn't going to work either. They function in the same way. Okay. So for and just as a note, going back to telling you, like, understanding how the drug works and what's going on in the body and how it affects that. If my patient, if their issue is, my patient has type 1 diabetes and their issue is that they cannot produce insulin, is this drug going to help me? No, because it doesn't have it to release. Does that make sense? So different drugs with this, there are increased hypoglycemia with gemfibrozole, erythromycin, and chloramphenicol. Don't you love those? And then decreased hypoglycemic, so it's not going to work as well, with alcohol, corticosteroids, and rifampin. On several of these, you're going to see antibiotics. And so I would encourage y'all, like, I might retract this statement, but being familiar with that, right? Like antibiotics, if you notice that a patient is on antibiotics, that you should be cautious in administering their medication. Okay. For the, good God, glitazones. That's what we're gonna call it. I'm so mad at myself because I purposely like went and practiced and it has left my brain. Thiazolidinedions. There we go. I think that's the word. Yeah, dienes. The end of it's dienes. I'm not going with the rest. These reduce our insulin resistance in our tissues. And so, same concept, I have to have insulin there for them to be able to respond to. Okay. And so you might have to administer this along with insulin for it to be able to work, or with metformin because it's increased, or the sulfonylureas because it's increased that release. Some side effects of these can be fluid retention. So who wouldn't I want to give this to? Very good. People who have issues with their fluid, right? If somebody's in heart failure, this would not be somebody I want to give this to. It can cause liver injury, so I want to monitor their liver function. It puts them at an increased risk for bladder cancer, can increase ovulation in anovulatory women. So you would for sure want to warn them of that because that would probably be scary. Elevations in their HDL and LDL and their triglycerides, which makes sense because your liver function is impacted. This is usually given once daily with or without food. And I wouldn't want to give that, like I said, people with heart failure or other types of heart disease or liver disease. And this isn't going to work in somebody with type 1 diabetes because they don't have insulin to use. Okay. The alpha glucosidase inhibitors, these are going to stop an enzyme that breaks down carbs in the intestine, which slows the carb absorption after meal. Okay, so they're going to stop that from happening. And this is going to help improve their A1C levels. So we didn't talk about this, but your A1C is a value that reflects your blood sugar control over about 3 months. Generally, you're shooting for a level under 7. Okay. So that will give you a better indicator. Like, I can't tell you how many times patients have came in and been like, my blood sugar does not run high. It doesn't. And then you check their A1C and it's 11 or something, and you're like, are you sure? But sometimes maybe they're telling the truth. I said if they're stressed, if they have some sort of illness, whatever, that can contribute to that. So the side effects of this mainly are GI type issues. I want to make sure that I take this with food 3 times a day. And because this is functioning like the enzyme that's already in my body, because of the GI potential, make sure that you use cautiously with people who have ulcerative colitis, IBS, bowel obstruction, or if they have liver impairment. You will continuously hear or see liver impairment with administering medications. The gliptin, this is also going to change an enzyme or a hormone, the incretin hormone, which stops the enzymes that inactivate it. So incretin is going to help insulin be released and decrease glucagon. Okay, so that is how it is helping to lower our blood sugar. And this can cause respiratory illness. That particular kind, pretty sure that's Januvia sitagliptin, can cause Stevens-Johnson syndrome. I'm going to let y'all look that up on your own because I forgot to say this when we were going over drug cards, but as you're writing those things down, you're going to read things like neuroleptic malignant syndrome, extrapyramidal symptoms, Stevens-Johnson syndrome, and I'm not giving you full credit if that's written on your drug card with nothing further. I need you to know what Stevens-Johnson syndrome is going to look like, because otherwise, how are you looking for it? Okay, you can write it, but say what that's going to look like. So I'll let y'all look that up. Contraindications are type 1 diabetes and DKA, and this can also increase digoxin levels. So if my patient is on digoxin, I would have to monitor that more closely, or probably I'm not giving this to people who are, excuse me, on digoxin, if I can help it. So the other kind, these are just a repeat of what we already talked about. The other kind is a sodium glucose cotransporter 2, or SGLT2. Like, who in the heck is naming these? These are used in combo with insulin for type 1 diabetes, and it helps to prevent that post-meal rise of your blood sugar. And by excreting glucose through the urine, because it prevents its reabsorption by the kidneys. Okay, so this is all about excreting it through urine. Okay, and this does promote weight loss. This is an example. The flazocin or gliflozin, the little from there further, is your clue on these types of drugs. They all kind of have that ending. So major side effects of this, I think I'm going to talk about this in a second. Yes. With glipizide, hypoglycemia, or weight gain are potential things that can happen. Metformin, the biggest things are GI, rarely lactic acidosis, but that is a big deal. And then B12 and folic acid. So if I see my patient has a bright red tongue, that could indicate that that's going on. The canagliflozin, because that is involving urine, because that's how I'm excreting that, potential complications are going to be related to that. So they might have increased urine, they might have yeast infections, they might have kidney infections because there's excess sugar being excreted through their urine, if that makes sense. And then they're also at risk for dizziness and hypotension. So for glipizide, I want to make sure I give that 30 minutes before breakfast. I want to hold if they are MPO or they're unable to eat. The metformin, they take that twice a day. And if they're on the immediate release or once daily, if they're on the sustained, the canagliflozin once a day before breakfast. Monitor their blood sugar with all of these. I will say for metformin, because like I said, it doesn't necessarily drop their blood sugar significantly. It will, but not to some great degree. That's less of a concern. You still do want to know their blood sugar, but that is less of a concern. One of the biggest things with metformin is that it can cause kidney issues. And so you want to make sure that if they have renal failure or if they are having a procedure where they're have to use IV dye, that we hold their metformin for 48 hours. Okay. For the amylin, this works similar to the hormone amylin, and they lower our blood sugar during meals, and also are going to delay the emptying of our stomach, and increase the feeling of fullness, like satiety feeling. This can be used for type 1 and 2 diabetes, and usually this is used in addition to and not as sole treatment. Adverse effects of this are going to be hypoglycemia, nausea, especially if the patients have type 1 diabetes, and then we do want to make sure that they titrate, and that's going to be true for both of these, the incretin and the amylin. They are started on an initial dose and their blood sugar control is maintained. Their side effects are monitored to make sure that it's not dropping their blood sugar too much, or they're not having too many GI issues or other complications. Make sure that we already know not to do this, that I am not mixing insulin in the same syringe. As my dose increases, they may be able to decrease the amount of insulin that they're on. Okay. The incretin mimetics, this is going to be GLP-1. So Ozempic is all the rage. That's going to fall into this category. So it's going to function like incretin does in our body. So this is going to reduce that after meal blood glucose drop, slows our gastric emptying, helps with that full feeling. Decreases glucagon secretion and also stimulates insulin to release. So this can also this can be used as for type 2 diabetes. And then adverse effects of this are hypoglycemia, especially if they take a sulfonylurea. And then GI effects are a big deal with this. Pancreatitis is a risk associated with incretin, and again, those are dosed up based on how the patient is handling it, basically. There is an increased risk for cardiovascular side effects, so you either would want to avoid that or use cautiously in people who have cardiovascular issues. Those are given sub-Q. I am going to expect y'all to know what the sub-Q sites are. And then usually that is in a pre-dosed pen where those can be adjusted. For hyperglycemics, these are going to increase the blood sugar. Okay, so we said that we can just eat sugar, or they can give dextrose or glucagon. So I will also say that I discussed that like emergency treatment if you're just pushing 50% dextrose. But sometimes, like if a patient isn't eating and they have diabetes, then sometimes they'll put them like on a dextrose infusion where they're getting their IV fluids have dextrose in it just to keep a constant rate. So same thing would be like if somebody isn't eating and they have nutritional deficits and they don't anticipate that, but like maybe they haven't started them on uh, TPN or tube feedings or something like that yet, they'll give them IV dextrose to just stabilize that. But it's at a lesser concentration and is an infusion versus a push, if that makes sense. So the push 50% is for a emergency reversal. Glucagon can also be given. It is going to raise glucose levels. It can cause GI effects. And glucagon can be given IV, IM, or sub-Q. Dextrose is given IV. If glucagon is given, then it can increase bleeding with Coumadin or warfarin or oral anticoagulants. It is going to negate what insulin would do, obviously. And if they are on phenytoin, which is a seizure drug, then it can stop the action of glucagon. So I would want to be aware of that. I think we've already talked about these, but that would be good questions for you to look at yourself of when you would do emergency type treatments, when you would hold them, and how would you make those decisions. So the nurse is discussing diabetes management with regular Humulin R. The nurse should include which of the following instructions? Select all that apply. Our favorite types of questions. Is it A? I'm carrying a carb snack. I'm rotating my site. I'm wearing a bracelet. And I need to adjust my dose when I'm sick, right? Because I'm going to have increased needs. My blood sugar is going to be higher. The nurse gives a client 5 units of Lispro insulin and 10 units of insulin glargine sub-Q at 1400. When should the nurse anticipate the client's blood glucose to be at its lowest?
So like after 6 hours.
Who votes B?
Right. The hero.
So you are I'm giving both of these, right? So I am determining when this is going to be its lowest. I'm going to get rid of the fact that I'm going to eat, it's going to drop, it's going to rise, whatever, right? But after I give rapid insulin, what's going to happen? It's going to drop, right? And then I've also given them something that is helping sustain that at a lower rate. So the lowest it's going to be is going to be after I give rapid insulin.
I was right.
Usually within like a couple of hours. Yes. Yes. Mm-hmm. They did eat. They had to before I gave it. Yes. Okay, just kidding. It's A. I'm misinterpreting those two numbers. It's A. So they have I just gave them the rapid, right? And then they are eating. And then I'm gonna have to do that again. But the glargine is going to drop it. So I do have to consider that. But it's the rapid is what is making the bigger difference here. Sorry for saying the wrong answer. Yes.
You're supposed to mix it with other insulin substitutes.
Correct. Yes. Very good question. So I think a lot of times there's a couple of things that are just like get very concrete when you hear them. So what she asked was when I said don't mix them, did she mean that I can't give them at the same time? I mean don't mix them in this syringe. I can't do that. Giving them at the same time is fine. Same concept. I overheard someone earlier when somebody opened the syringe, drew up the medicine, and went to go put these back together, do exactly that and say, you can't recap a needle. So if I'm in the med room and I draw this up, y'all want me to? I'm coming, Rhonda. That is not. That's not what we're talking about. If I if I if I trip and fall, I'm stabbing myself with a needle. Okay. So what they mean, first of all, never ever ever in my entire life am I doing this. Right? I'm not doing that. But if there's no safety on here, probably the ones that y'all are using are going to have a little cover where you can just slide that up and you can use that. I don't have one. This pretend right here. But I could use that. But I can recap this. Why am I not recapping needles? Because I don't want whatever is on their blood in mine. So if I just drew up medicine, I can recap this to walk to their room, right? I do. I just did. Yeah. I No, never am I just doing that in my hand, but that's what that means. Not never in a million years are you putting a cap back on. Never in a million years after you just stab somebody with a needle are you putting that cap back on. No. Correct. Yes. Otherwise you're doing this, which does not seem safe. Yes. Huh? Oh. Okay. So what we're going to do, do we have another one?